Our next speakers know the challenges of gun violence. Both are practicing emergency physicians. Both have extensively published research on preventing firearm-related deaths and injuries, and both are actively involved in combating gun violence in their own communities. First, Dr. AMA Betz is an associate professor of emergency medicine at the University of Colorado School of Medicine. Dr. Betz's research expertise is in care of suicidal patients, as well as provider attitudes toward lethal means restriction, public opinion about firearm safety discussions, and strategies for enhancing provider-patient communication about sensitive subjects. Next, Dr. Megan Ranney is an assistant professor in the Department of Emergency Medicine at Brown University. Dr. Ranney's research expertise is in firearm violence prevention and digital health interventions for patients with a history of violence. Please join me in welcoming Drs. Betz and Ranney. Thank you.
Thank you so much for the invitation, and thank you so much to everyone who has stuck it out for what has been an interesting but also long afternoon. So I am a practicing emergency physician. I do a lot of research mostly in suicide prevention. If you want the 6-minute abbreviated version of this talk, I have a TED Talk from a few years ago. I have no conflicts of interest for this presentation. And I also want to just take a step back for a moment and acknowledge something that I think we haven't talked about as much today, which is that all of us, myself included, have, as individuals, I think, complex views on firearms. Earlier, someone said, for physicians in particular, that this isn't political, it's personal. And I think that's true in how we approach our patients, and we need to recognize our patients have complex views around firearms, as do our colleagues, as do many of us. So I work in the ER, and I every day see senseless tragedies, whether it's premature deaths or the collateral damage of people healing from injuries, people who've lost others to gun violence. And I, like Dr. Ranney and my colleagues, are very frustrated and want to do more to prevent this. But I am also a proud native of Colorado and a state with a rich heritage and things like hunting. In the photo, that's my beloved father-in-law on the right, who is a very responsible hunter. And when my girls are old enough, if they want to go hunting with him, I would absolutely support that. I, like many people, though, have also lost many friends and family members to suicide, most recently just 4 months ago, when my cousin Ian took his life with a firearm. And my family is still reeling from this and trying to work through it. And I mean, I work in this field, and we didn't expect it and weren't able to prevent it. And so how is it that on the one hand, I can have family members who hunt and I can support that, and on the other hand, also really firsthand feel what, in a moment of impulsivity, a gun can do? And then, to make it even more complex, in Colorado, I do a lot of work with firearm groups and firearm owners, which has been really fascinating and has really changed my thinking about this. I've taken a firearm safety course and been to the range. I am a terrible shot, and that's okay with me. But it's really helped me start to learn why it is that people own guns, and there are a lot of reasons why. And I think for physicians in particular, I think it's very important that we take that step back, think about our own views, our own biases, and try to meet our patients where they are at. We're certainly entitled to our own political opinions, and I have my own opinions about all the other wonderful work going on, but when I'm working with a patient, I need to, I think, really check those at the door. So one of the questions I think that comes up is, should doctors talk about guns? There are some people who would say no. There are people on one end of the spectrum who think we are the agents of Big Brother coming to record whether they own guns, and that's the first step towards confiscation. On the other end of the spectrum, there are people who say absolutely, but that should only be to be adamant about the fact that no one should ever own a gun, and the only safe home is one without one. And I have had colleagues say to me that they think the work I do collaborating with gun owners is unethical and that I'm sending wrong and mixed messages. I would say, and I think Dr. Ranney would agree, emphatically, yes, absolutely, physicians should be talking to patients about guns. But I think there are times and ways to do it that are appropriate. And I think especially for what a politicized topic this is, that we need to be aware of how we are doing this and not making it easy for physicians to become yet another sort of demonized group who's out for confiscation. And that's a lot of what we're going to talk about today, is how hopefully we can encourage people to do this. So absolutely, yes, physicians as well as physician organizations can and should do their part to help reduce firearm injuries and deaths. But importantly, we can do it using evidence, and I think it's very important that we use evidence-based methods, and we can do it using methods that are acceptable to both patients and providers. And I would really urge that we keep a focus on the second half of this clause. And I hope that at least some of you at the end of today will leave energized and thinking about new things that you could be doing even tomorrow to help towards this goal. I'm not going to talk about the case. Thank you very much to everyone who's involved. We are thrilled to have the Florida case overturned. And I put it here just to make it very clear that as of right now, thanks to our legal friends, no state or federal laws prohibit physicians from talking to their patients about firearms. And it's something that, as I've said, we can and should be doing in the right circumstances. Why else should we be talking about guns? Well, we're already involved. As I mentioned, we already care for patients who have been victims of violence, who are at risk of being victims of violence, who know people who've been victims of violence. We also now have to worry about hospital and clinic safety. We have code silvers for active shooters. Megan and I are part of a Facebook group of physician docs where there was just a very active, heated debate about whether emergency physicians should conceal carry at work under their scrubs, which it was a sort of mind-boggling debate to me, but I think hospitals are going to have to come up with policies, hospitals, outpatient clinics, and so forth, around concealed carry or open carry during patient encounters, and what are the policies both for patients as well as for healthcare providers. And then there are a lot of legal questions. I apologize to the lawyers for the icon with the dollar bill sign. My husband is a lawyer and was offended by it, but it was the best one that I could find. So I hope you can take it with humor. There are a lot of questions that we really need help on today, tomorrow, and in the future, because I think sometimes what is preventing physicians from asking and talking about these tough issues is that they don't know what's legal. So the gag law, for example, had clauses that even when it was in place allowed physicians to talk about it. Absolutely, that gag law is a terrible thing, and we should not have legislation saying what we can and can't discuss with patients. But we as physicians also need to know what we actually can do in the moment. And there are still lots of questions around what you can recommend in terms of transfer of firearms. If you have someone who's at risk of domestic violence, are you allowed to call the police? Are you not? How does it vary by state, and so forth? And so we need active, ongoing guidance about these things. And going back to, I think, something that Dr. Miller was showing or tried to show earlier, that gun deaths affect all of us. This map shows the United States, obviously, but with total firearm death rates, not just suicides, the blue high rates, the white lower rates. The point of this is just to show there's a lot of variation, and we all come from communities with different issues. The issues facing you here in Chicago are different than the ones that I face when I think about rural communities in Colorado. That's not to say one is more or less important than the other, but just that we need to understand the patterns where we live so we can begin to address them. We also know firearm ownership varies by state. Again, blue high, up over 40%, and then the light or lower rates. And even in states with similar firearm ownership rates, I would argue that the culture probably varies, and there's a lot we don't know about. I think Southern gun culture is very different than Western gun culture, for example, and inner city versus rural. And understanding, again, the patient communities where we practice is important in thinking about how we can most effectively work with those patients to help keep them safe. So the other reason why physicians should be involved in this is absolutely we are piece of the solution. But I put this here also as a reminder that we are not the cure-all. We can't do this alone, of course not. We need the legal, the policy approaches. We need community education and community interventions. But those things are not a reason for us to stay silent, and I think physicians can and really need to be playing a more active role in how they work with patients and what they as as through their organizations, are doing to reduce gun violence. So what Megan and I are going to try to tackle in this last session, I'm going to do a little bit, some numbers and a framework for action, which hopefully will expand on Matt's talk, but with a focus more on physicians. And then Megan's going to go through some very specific things that we can be doing now, both in the exam room and outside of the exam room. And then we look forward to your questions. So some this may be a brief review for those of you getting ready for the quiz at the end. Who is it who's dying? And I want to show these again because I think as we as physicians want to know the patient populations that we are thinking about and who is at risk and what patient populations are we reaching or do we need to be reaching. It certainly is relevant for people doing work outside of medicine as well, though. So these are data from 2014. The y-axis is showing number of deaths and then age groups. So this is males dying. And what you can see is there's this big spike in the sort of 15 to 25-year-old range that's driven predominantly by interpersonal violence. And then there's this another hump in the middle and older ages, driven predominantly by suicide. If you throw females on there, you can see across all age groups, the numbers are much lower, such that males account for about 85% of all gun deaths in the United States. Not saying that the female deaths aren't important, certainly, but just to put this all in perspective. So if we look a little more closely at men, what's going on? This is now looking at non-Hispanic whites, and you can see that the big peak is in the sort of 40 to 70-year-old really age range, really driven by suicide. So it's older white men dying by suicide. Then African American men, you can see it's a very different pattern. And if I showed you the rates, it would be an even higher spike because this is absolute numbers and there are far more white men than African American men in this country, but driven really by interpersonal violence. And this is, I think, highlighting something that has come up over today and is really important to remember that there are different problems in different communities and there are going to be different solutions. And I think it's important that we don't hurt each other in our attempts to solve these issues, that we need to remember the bigger picture and that each one of these is a life lost and we're equally worthy of being saved. And then Hispanics have a pattern somewhat similar to the non-Hispanic blacks, but at lower numbers. Such that in 2014, about 2/3 of all gun deaths among men were among whites. And so then the question is, well, why are they dying? What are the causes? And we've touched on this today, but I think it's worth going over again. So this is 2013 data because this is when I got the last data on mass shootings, which vary in their definition. But so 1.5% of all gun deaths in the U.S. are the so-called accidental deaths, which are horrifically tragic. The toddler who finds a gun, who shoots a friend or shoots himself and so forth. Horrific and need to be prevented, absolutely. But they're also a very small piece of the puzzle. So even if we were perfect at getting parents to be safe with their kids, there would still be a lot of deaths. Mass shootings are even tinier. They're the things that get all of the attention, and they are also horrific and tragic, but again, very small numbers. And about 1/3 are homicide and legal intervention, which includes police-involved shootings, and then the remainder are suicides. So again, just putting this all in context, I think the suicides in particular are often left out of the discussion. I recognize I am a suicide researcher, so I have a lens through which I view everything, but I think when we don't talk about these deaths, we're implying that they somehow are either not preventable or not worthy of prevention. And this will just be going over again a bit what Matt spoke about earlier, why it is that when we talk about suicide and why we talk about firearms and suicide, we need to really talk about them together. We know that only 10% of people who have been suicidal or have even had an attempt later die by suicide. Yet we know that 90% of people who reach for a gun in the midst of their crisis will die. And we know that final decision is often very impulsive, as he spoke about, sometimes within only an hour. And so when we talk about suicide prevention, and particularly what physicians are counseling, it's from our angle, it's not so much who can or can't buy a gun in the first place. It's about how is it stored. When you're in this bad period, can you get it out of the house? Can you lock it up so someone else has the key? analogous to sort of drunk driving. Can you just separate yourself from the risk during this period of crisis? And I'll give a brief shout out to the VA. I think they're really leading the way in this work and doing really phenomenal work and at full on tackling the firearm suicide issue among veterans. Also, to put firearm deaths in context, this is with as compared to some other death rates. So we hear, if you work in medicine at least, you hear a lot about sepsis or sort of overwhelming infection or inflammation. Firearms have a somewhat similar death rate. And imagine if we had as many quality indicators for firearm deaths as we do for sepsis. Diabetes is about twice that of firearms. Again, not to say any of these is more or less important, but just to put it in context, and this is why this is something we should be talking about. So I'm now going to talk a little bit about the framework for action that Matt was using earlier, but also highlighting in particular the role of physicians in that framework. So as he spoke about, we need surveillance. We certainly need to know what the scope of the problem is, because then we can work to identify risk and protective factors, figure out how to intervene with certain populations. We then evaluate those interventions, and then hopefully disseminate them. When we think about interventions, people sometimes talk about the 3 E's. So there's education, there's enforcement and enactment, and then engineering. Engineering would be, in this realm, would be things like smart guns. In the realm of traffic safety, it was better cars, rumble strips, airbags, and so forth. Enforcement and enactment is critically important. We won't be talking about that in this presentation, but is very important, and we're grateful for the work of our policy and legal colleagues. But education is often where physicians really have a role to play, and that's what we're really thinking about, is how do we educate patients in a one-on-one setting to help improve their safety. And then, as I mentioned, hopefully you figure out what works and then you implement it. And the reason we recommend this is because we know it works. So this is going back a bit to what Matt was speaking about. We think about some of the successes in the past and can use them as models. So this next chart is showing death rates in the United States. So the y-axis is the mortality rate per population, and then you can see the years along the x-axis from 1950 to the present. So this is what happened with car crashes, and Matt went through why this was. So yes, we had some driver education, but what really did it was better cars, it was better roads, it was better enforcement, it was changing norms around drunk driving, changing norms around using car seats, understanding the periods of risk for teen drivers, and then enacting and enforcing laws that specifically address that in a data-driven way, and we've had phenomenal successes. Another example I find very interesting, and one that was actually suggested to me by my firearms instructor, is the HIV/AIDS epidemic, which really shot up in the 1990s. Certainly then came down largely because of the engineering of drugs to treat the infection. But I think it's really useful in this context in thinking about what physicians had to learn how to do. They had to learn how to talk about risk factors for HIV, so sexual practices, drug use, things that probably many of them were not very familiar with, maybe not even comfortable with, and they had to learn how to make their clinic a safe space, how to interact with patients in a way that was respectful, that showed empathy, that was non-judgmental, to encourage patients to be tested and be treated. And I think we can take a lot. We can use that as a model for how physicians really need to learn how to talk about firearms with patients. And then just for comparison, here's the firearm death rate. So, right, we have not applied the same kind of comprehensive approach, and so we're about where we have been. Briefly, before I turn it over to Megan, I do want to highlight the importance of advocating for funding. This is a really interesting article that came out in JAMA in January, I believe, looking at relative funding, mortality versus funding. So on the y-axis is funding in billions of dollars from federal organizations like the NIH, and across the x-axis is the mortality rate. And they fit a line, basically, that's sort of saying roughly for mortality, here's what it seems like diseases get. And so gun violence, you can see, falls very low. Based on its mortality rate, it gets, in fact, only about 1.6% of what would have been predicted for funding. So it's way underfunded, and that's a very long and interesting story about why. But for example, sepsis that I was talking about earlier with a similar mortality rate, you can see gets far more funding. Again, not saying that diseases above the line shouldn't be getting funding, but just that if we want to address this like the public health and medical issue that it is, we need to research it in the same way. The CDC certainly is still silenced. NIH has started funding, and NIJ has started funding, but the CDC, if you go to their webpage, for example, they have all these health topics with information for consumers. They have nail guns, they have fireworks, firearms, and guns are completely missing, which I find just it continues to offend me. That if you think of the CDC as a source for public education, it's not anywhere there. And even the representative who proposed the original amendment that became the de facto ban on federal funding has now said, look, there's a way that we can do this that is still respectful. There's a way that we can research these issues, just as I would argue there's a way that we can be talking to patients and we can be counseling patients that is respectful and is not infringing on Second Amendment rights. And I'm going to turn it over to Megan now to continue on to sort of next steps. Thank you.
Thank you. Thanks, Emmy. So as a recap, right, so we've talked about numbers and we've talked about the framework for action, and now we're going to move on to what we as physicians can do. So my disclosures, I also have no conflicts of interest with this specific talk. I do have federal funding. I chair a work group within the American College of Emergency Physicians on firearm injury, and I'm a member of the Society for Academic Emergency Medicine Board of Directors. So let me talk a little bit about actions. So in the exam room, when and how we as physicians can talk to our patients about firearms. So I want to kind of refocus us here. So traditionally, the medical model of the approach to firearm injury focuses on the right-hand side of the screen. As an emergency physician, I spent a lot of time in my training learning how to resuscitate patients after a shooting, right? We have a ton of research about, do we do permissive hypotension or do we give them a lot of IV fluids in the ambulance? At what point do we crack their chest? Is it better to do a DPL or just take them to the OR? And we talk a ton about how do we resuscitate, how do we minimize mortality after the firearm injury has happened? And we often ignore within medicine that whole downstream series of events that led to the shooting, right? Yet we know that for firearm injuries, just as for anything else that we deal with in medicine, there are predecessors to that moment of shooting. And Matt and Emmy have talked about how with car crashes, we identified those earlier risk factors and have intervened. We do it for MIs, for pulmonary embolism, for bad diabetes. In the medical model, we are used to identifying risk factors and intervening in them. We also know in medicine and for firearms that there are moments where risk elevates and where it makes sense to do more. So for instance, for people at risk of heart attack, if someone comes into my ER complaining of chest pain, I'm going to do a lot more testing and risk stratification and do more intensive behavioral interventions than I would if I were seeing someone as a primary care practice doctor for someone who has no risk factors and has never had chest pain, right? And so there's this moment where we can say, wow, you're really a little more high risk and let me do an intervention for you. And we do that for drinking, we do that for smoking, we do that for a number of different things. And for firearms as well, I would argue that there is a moment where we can and should intervene. If we do that intervention in the right way, we will likely prevent a large percentage of shootings. We won't prevent all of them, just as we don't prevent all car crashes or all heart attacks. We will prevent the need for that resuscitation, which my trauma surgery colleagues won't be so happy about, but which make the emergency physicians thrilled. And then importantly, we then prevent that downstream cascade of consequences, which other people have talked about. The fact that after a shooting, it leads to other shootings, right? There's the contagion of violence. It leads to PTSD if you survive a shooting or in your family members, your community members. There have been a number of studies showing that community violence is one of the biggest predictors of PTSD. It leads to downstream effects on our doctors, on our EMS, and on our nurses. There's secondary PTSD and burnout that happens because of taking care for this population that has recidivism over and over. Or I will never forget one of my first cases as an attending was a young man who shot himself in the head with his father's gun, and his father was one of our police chiefs in my town. And so all the police officers from the town came in basically so that I could pronounce this guy dead. And the effect on my community, on my EMS providers, our police officers, and the physicians in my, the techs, et cetera, in my ER was tremendous. And so there's all of these downstream effects that can be stopped if we can intervene at that moment of escalation of risk factors. Unfortunately, as you have heard kind of ad nauseum, we don't know super well yet, because of the lack of research funding, when that moment of escalation of risk happens. You know, I know forensic psychologists try to look into the psychology of mass killers. We don't know. We can't predict when someone is about to commit suicide, when someone is about to commit a homicide. We may never create perfect risk prediction models, particularly with the lack of funding, but that doesn't stop us from having to assess this. As an emergency physician, I don't get a choice of who walks through my doors. I don't get a choice of when I get brought someone telling they're there for a danger assessment, right? And we know already from the literature that exists that there are at a minimum 3 very high-risk conditions where we can and must screen for access to a firearm. And those 3 conditions are: first, suicide, right? So if someone comes in with suicidal ideation and they have access to a gun and they try to commit suicide with a gun, 90% of those attempts will be fatal versus 10% of attempts with all other methods combined. Second, if someone comes in and they have come in for an assault-related injury or with a history of assault, and I have a colleague here from University of Michigan, they have done some of the leading research showing that 50 to 60% of youth with a history of assault are going to experience another. Youth with a history of pure violence and access to a firearm are almost 2 times more likely to experience a firearm assault. And then someone who's been hospitalized for firearm-related injury is over 330 times more likely to have another firearm-related injury compared to someone who's been hospitalized for a motor vehicle crash. So the fact that someone has experienced an assault is a marker that they are at risk and that we should be talking about firearms with them. Finally, domestic violence. Another kind of the upsetting cases that I've seen as physicians that have motivated me to go into this work was a domestic violence patient who came in, beat up by her boyfriend, told me that her partner had access to firearms. I called the police, and they said, she doesn't have a restraining order, and I guess if we run into him, maybe we'll do something about it. I'm like, awesome. So I'm going to send this woman back out onto the street with her partner having a firearm. We know that women whose partners own a firearm or who own a firearm themselves have 5 times the risk of death from partner violence, right? And so these 3 populations are one that we have to be asking about whether they have access. There's also some data that other populations, those with alcohol or substance abuse, as we've heard about, those who are cognitively impaired. So with the baby boomers, rising population of folks with Alzheimer's and cognitive impairment, many of them have guns, and we know there are higher rates of unintentional or accidental injury, as well as suicide in that population. And of course, kids. We talked about the very low rate of accidental injuries among kids, but they do happen, and they are tragic, and they are preventable. And so I would say that these are populations that we should consider talking about while we also kind of create more evidence. And if we screen those groups, we find that they have similar rates of firearm ownership, similar or higher, to the rest of the American population. So if you look at kids, 30% of them, including 30% of kids with mental health problems, have access to a gun. Teens who are seen in the emergency department with an assault injury in Flint, Michigan, between 30 and 40% of them had access to a firearm. 30% of battered women, and in one study, 60% of Alzheimer's patients seen in a treatment clinic for a cognitive decline had access to a firearm. So this is something important for us to talk about. When I screen for someone who comes in with chest pain and I ask, do you have a family history of heart disease? I don't ever reach 30% of people that I ask that question who have that as a risk factor. So this is incredibly important for us as physicians to talk about. And then what do you do? So we have a lot of talk in medicine about kind of the burden of doing preventive medicine and screening. There was one study that showed that if we did all the preventive medicine that we were supposed to, it would take up like 8 hours a day, and you wouldn't have time to provide the care that you need to do for other kind of acute medical issues. But we know that for many conditions, doing screening, brief interventions, and referrals to treatment for people who are kind of more severe work. And we know that for firearms, that similar approach of SBIRT works as well. It does not have to take a lot of time. And the message is a very simple one, which Dr. Betz talked about and others have as well. It's the idea of reducing access for those at risk. And this takes us out of the political debate, out of the policy debate, which, although incredibly important, is not so much my role in the exam room with the patient, right? It's the idea that ideally safe storage is a long-term practice, but in those moments of acute risk, it's about reducing access. So the woman who tells me that she's a victim of domestic violence, but she carries a gun in her purse so that her partner won't get her, it's about counseling her about how that increases her risk. For the family of the suicidal teen, it's about talking to them about maybe storing the gun out of the house or keeping it locked up until the kid has gotten appropriate help and is no longer suicidal. It is importantly not about confiscation of firearms. It is not about getting rid of guns. It's about doing what we do as physicians, which is promoting health within our patients. Studies show that patients are okay with this, despite the Docs versus Glocks case that was actually based on just a couple of anecdotes, but the vast majority of patients, including gun owners, say that it is absolutely okay to ask, as long as you do it in a way that's individualized, that doesn't single me out, that doesn't lecture me, and that it is, as always, culturally competent. So like Dr. Betz discussed, if I'm working in Colorado versus where I am in Rhode Island, I'm probably going to have a different discussion. And here language matters. So instead of saying, you must get rid of your guns, you can say things like, what do you think about storing your guns off-site until the situation improves? Or have you thought about how to keep your kids safe around your guns? Or let's talk about how to lower the risk of your boyfriend hurting or killing you. There's the same techniques that we use for other forms of risk reduction, for unsafe sex, for drug use, for alcohol use. This is not unfamiliar language to physicians, but it's a process of teaching us about how to use it. And this works. So there is limited evidence that these sort of physician-led interventions do work. These studies were all done with NIH funding, and I call that out again because there is virtually no NIH funding. There are 12 large grants that have been funded by NIH around firearms, and despite a number of grants having gotten very good scores, there is no sign that they are releasing more funding on firearms anytime soon. But when you do a good study with real money, we've shown that if you give families brief counseling and a trigger lock, they increase the rates of safe storage. If we do complex interventions in the emergency department or in trauma services, things like violence intervention programs, things like very brief interventions. So one study from University of Michigan, they basically gave kids a tablet computer with a brief intervention, led and kind of had a therapist walk them through it. Took about 15, 20 minutes, and they showed decrease in fights, decrease in weapon carriage. This does not have to be super, super complex. There are some studies that show that families of suicidal teens may lock up guns if counseled appropriately, and I know that Dr. Miller, Dr. Betz, and colleagues are doing more work on this. Despite the fact that we have evidence, we don't do it. So this is a study that Betz and Miller did showing that when emergency physicians are discharging a suicidal patient home, we ask less than 1/3 of them whether they have access to guns, even when they actually have a gun at home. So we are not doing a good job of practicing this, even with a limited evidence base, we have not effectively put it into practice yet. And so there's a huge role here for us to do better as physicians in doing the very minimum, right? Ask your suicidal patients if they have a firearm. The reasons why are a number. So barriers to asking include time, knowledge, lack of resources, and lack of comfort. So physician ownership of firearms mirrors that of the rest of the country. About 30% of us are firearm owners. And for people who aren't firearm owners, they may have discomfort with asking. They may not know how to deal with questions or how to appropriately counsel. Again, as physicians, we need to create resources for ourselves to make our colleagues feel comfortable with that process. And there is the perception about the gag laws, which thank goodness have been overturned, but I understand based on a discussion I had earlier today that there are 11 states that have proposals around potentially putting other gag laws in place. These are unacceptable for a wide variety of reasons. And that actually leads me into the final topic that we're going to talk about today, which is what actions can we take outside the exam room. So there's all this stuff we can be doing in the exam room, but we're not doing. And I think a lot of the reason why is because we have to improve our collaboration. And that's why we're so honored to be here today talking to you in this very multidisciplinary environment with lawyers who can help us with those policy changes and advocacy that need to take place. So here, really, what we need to do is to collaborate and remove barriers. So again, here I will note that firearm ownership and types and numbers of death vary by state. So the types of discussions that we should be having, although I agree with the comment that I think it was Harold Pollack made about the fact that we have local laws around gun ownership, and yet national trafficking impacts our ability to reduce the flow of illegal guns. At the same time, when we're talking about policy change and specific community interventions, there is going to be a state-by-state difference. So for Colorado versus for Rhode Island, Texas, my colleagues are dealing with the open carry laws. University of Texas Medical Center, they're having to put in storage lockers in the University of Texas Medical Centers for all the docs and nurses who carry to work with them. There's a wide variety of issues that are going to be very locally dependent. And we have to acknowledge them. As much as I wish it weren't so, it is. And the important thing here is to know that although views may vary, collaboration is absolutely possible, and we can reach across the proverbial aisle, right, and create collaboration between groups. Emmy talked a little bit about her work with firearm safety groups, but this is a picture of a collaboration between the American Foundation for Suicide Prevention and the National Shooting Sports Foundation, which is not as crazy as the NRA, but they've done a really nice job of collaborating to create some really nice suicide prevention messages. So some examples of some partnerships. This really started with the New Hampshire Firearm Safety Coalition, which was led by Deb Azriel in collaboration with the Harvard Injury Control Research Center. Emmy in Colorado has been doing a lot of work, but it has expanded really across many of the states across our country. It started based on suicide, but it has included things like having ladies' nights where they talk about domestic violence and youth suicide prevention. It's included things like firearm instructor modules, putting placements in diners, having an app for safer homes. Gun shops have shown interest. So we've had gun owners who have said, God, I sold this gun to this guy, and then I found out he killed himself. That was never my intention, right? And so gun shop owners, if you talk to them in the right way, are interested and willing in having this discussion. And again, this is about not demonizing gun owners, the 30% of our population who own. It's about how do we get them into this conversation and help them own more safely. And then, of course, decrease or prevent gun ownership among the rest of them. Another example of community collaboration is things like the National Network of Hospital-Based Violence Intervention Programs. An example here, there's programs at Boston Medical Center in Oakland. A friend of mine, Rob Gore, runs a program called Kings Against Violence Initiative in Brooklyn, where you take physicians who deal with violence and you create partnerships between them and the communities that cure violence, right? So it's taking that sort of a thing and bringing it into the hospital and or taking docs out of the hospital into the community to talk about risks. And as Emmy mentioned, that there are kind of these bimodal epidemics of firearm violence, that there's interpersonal violence in young minority males, and then there is suicide in older white males. And this is something that is very important for communities that are more affected by the interpersonal violence. Another example of a collaboration, this is one that I'm particularly proud of and excited by, and I think will be very interesting to many of you. We had flyers out front. I and others in the audience have worked for the past year with the Massachusetts Medical Society and with the Attorney General of Massachusetts to create a series of resources for physicians answering our questions about what the laws let us do. So for instance, that patient who I took care of, who was a domestic violence patient, am I allowed to call the police, right? When can I violate HIPAA? When must I violate HIPAA? When I counsel a patient that they need to store their firearm off-site, is it legal for them to leave it with a family member? What are the legal kind of transfer options and safe storage options within our community? These are things that as doctors, I don't know. Like if I tried to read the Wolfschager opinion on the Docs versus Glocks, and my eyes glazed over. I don't get it. It's not my language. You guys get it, and you can help translate it for us so that when I'm in when my colleagues are in the office, or when I'm in the ED, or when I have a trauma surgeon who finds out that someone has 6 guns at home, we know what it is that we can legally do. And this is an example of the type of brochures that we created as part of with the Attorney General. And I just really have to give great credit to Maura Healy and John Miller and Ben Golden, who initiated and led this project. And the last type of collaboration is collaboration between medical groups. I mentioned that I'm active with an ASEP. I led an ASEP technical advisory group on firearm research, which recently published this consensus-driven agenda for emergency medicine firearm injury prevention research. But basically, we did a summary of what we need to know in order to do a better job taking care of our patients in the ED. We also have an ACEP high-threat task force that's doing things like looking at how do we respond to mass shootings, what data do we need in order to describe the epidemiology, et cetera. And then we've, of course, had a number of publications from other organizations, ranging from the American College of Surgeons, American Association of Pediatrics, AAFP, ACOG. The top is the Firearm-Related Injury and Death in the U.S. Call to Action from 8 organizations, including the ABA, so thank you for that. But we are increasingly collaborating together to say we need to do something as physicians. And when you look at all these documents that have been published, there's kind of a few big themes that come out about where we can change things. The first is we need research. We need research. We need federal funding. And if federal funding is not going to be there, we need to find alternative sources of funding. Without funding to develop those risk factors, to develop those interventions, and to develop an evidence base, we will not be able to move forward. The second is we need expansion and normalization of our data sets that we can do good epi research. We need to protect the right to ask and counsel, and we need to advocate for physicians to use that right. And then we need to really create best practices, similar to the Hartford Consensus for Mass Violence. We need similar best practices that are disseminated by our professional organizations for other types of firearm injury as well. So as a recap, we've talked about the numbers, right? So we've talked about suicide being more common and about the state-specific stats and about the fact that this is preventable. We've talked about the framework for action, the public health approach, the need for research funding. We've talked about the actions that many physicians are taking in the exam room, but that many more of us need to take and that we need to promote within our own societies, asking and counseling for high-risk groups. And then we've talked about actions that we can take outside the exam room, things we can do by working together to collaborate and to clarify for the benefit of our patients who we touch at this moment of intense need and vulnerability, at a moment when we can shift the needle, right? We can change behavior in the exam room for these high-risk patients if we are properly supported and have the proper tools. So I would urge us leaving to work on these things, to create a standard of care, which would be at a minimum ask people who are suicidal, victims of partner violence and street violence, develop legal guidance for docs. So for my lawyer friends in the room, please work with us to help us kind of clarify what it is that we can and should do in each state and municipality. We can collaborate across the political spectrum, not demonize the other side, but rather listen to them and work with them. And lastly, encourage research funding. We do have a short list of resources here. We're happy to provide more. And we just want to thank the ABA and the AMA for giving us this opportunity. So we welcome questions.
Again, if you would write your questions on a card and pass them down to the center aisle and collect it, and they have a question to
Yes.
start with here.
We start pre-prepared. So this one, I think I kind of answered, but what do you think medical societies ought to be doing to educate physicians about talking to patients about firearms? And then what about medical schools or residency programs? I think part of the challenge is that we haven't had that body of evidence, right? So for a physician group to undertake training, they really want to be sure there's best practices and evidence. I think we have growing evidence around suicide and peer violence and domestic violence, and that we can and should be disseminating those best practices within our physician groups. And I think we have a growing kind of group of us that are collaborating between kind of the large national physician organizations, and that we can take advantage of this momentum to disseminate to our residents and then to our med students. I think also it's important just for people to be familiar with what guns are. If you're going to be counseling on safe storage of a firearm, you should know what a trigger lock looks like and what a lockbox looks like, because otherwise you look kind of silly. But yeah, just like we teach them about what a condom is, it's a similar thing.
No, I think that's very true. When we think about physician education, some of it is just the real basics and understanding, for example, in the realm of counseling suicidal patients about access to guns, things like using the term lethal means safety as opposed to lethal means restriction, that the word restriction carries a really negative connotation, and that just understanding some of the pitfalls and understanding some very basics. We're not saying that physicians need to go out and buy guns and be gun experts, but in the same way that we don't, hopefully, most of us go become addicts to various kinds of drugs or try heroin, but we should understand the experiences of what patients are having. Let's see, I mixed up the order. How can behavioral health specialists help to reduce the incidence of gun-related injuries and deaths? So I would say that it depends a bit on the location where they're working, but our behavioral health specialists, psychologists, psychiatrists, et cetera, are key players in this. So in our ER, for example, we work very closely with behavioral health evaluators. Most of them are social workers by background. They have a lot more time to sit down with patients and go through things like full suicide risk assessments, but also talk about lethal means safety. And so they're absolutely key groups to be involved in training for the kinds of things that we're talking about. We're not suggesting that it's physicians who should be doing all of this. I think multidisciplinary teams are key. And then certainly behavioral health specialists working in independent settings also need the same kind of education if they're working with patients who are suicidal, counselors working with kids who've been exposed to violence, who are at risk of violence, domestic violence. We use the word physician a lot, but I think we would consider this to apply to all kinds of healthcare providers.
And I'll add there, so there was a great study done by Renee Johnson, who used to be at, or is still at Boston University, she used to be at BU, looking at CALM training of mental health, community mental health providers, increasing lethal means counseling. The other thing is that the study that I referenced that was done by Doug Zatzik actually used behavioral health specialists to provide PTSD treatment to kids who had been traumatically injured. And that was one of the things that decreased weapon carriage. So there's absolutely a role. Next question. Thank you for addressing domestic violence. You're welcome. It's really important to me. It's one of the reasons that I got into violence prevention. And then what is the gender breakdown for gun-related suicide deaths? Is this also mostly men? What % women? So mostly men.
It's mostly men, and I can get you the exact statistics. Dr. Miller probably knows them. Women are less likely than men to reach for guns, but certainly the fatality rates are the same. And we do know that among veterans, so female veterans are more likely than civilian veterans to use firearms. But do you know off the top of your head for women
versus men suicide? I think it's like 80-20, yeah? Yeah, 80% men, that is.
Right.
Men are just, there's something about testosterone. There's a big value in gender and sex-specific research. So, all right, for data sources, have you looked at trauma registries? Absolutely, we have looked at trauma registries, and I love trauma registries. I also have looked at the National EMS information system, so EMS also has some great data sets. The trouble is that each of these data sources has its limits. So the trauma registries only include patients who come in as a trauma, right, which is like a certain level of activation to be included in the trauma registry. Now, most gun injuries are trauma, but not all. In my hospital, for an extremity gunshot wound that doesn't threaten the limb, we don't activate the trauma team. So not all GSWs are going to be in the trauma registries. It also misses those people, and Pat Carter in the audience can certainly talk extensively about this, but it misses those people who are at risk but may not be there for a gunshot wound. So the ED visit is a moment when we can identify people who are at imminent risk of near-term death or injury, and if we only look at trauma registry data, we're going to miss that. So it's part of the picture, but we really need to synthesize a lot of different data sets. I don't know if you have other comments there.
No.
Okay. Can I take this one?
No,
All right.
you can.
Oh.
Well,
That's
a good one.
Yeah, from a physician perspective, any comments on the Obama regulation that would restrict gun sales to those with mental disabilities that was overturned by the GOP Congress in February? This regulation was opposed by patient and disability groups. So I have lots of it. So New York State, right? New York State has very, very stringent requirements around reporting of mental health disabilities for background checks, much more so than, so the national, I always get the acronym, but NICS, the National Information Criminal, whatever, the background check system, basically you only get reported to it if it's an involuntary commitment, which is a really, really high standard. Like, of all the patients that I've taken care of in the emergency department in 13 years of practicing, maybe 2 have gone before a judge and been committed, right? Most of them you do a 72-hour hold, or you get them to sign in voluntarily. So we're missing a lot of those people with 72-hour holds who are at higher risk. But by making physicians and mental health providers mandatory reporters, I think you're creating the same issue that you have for domestic violence, where then people are hesitant to disclose either firearm use or mental illness. And we don't want any more stigma and barriers to getting treatment for depression, PTSD, suicidality. We want to decrease that stigma and increase people's likelihood of disclosing so that we can save their lives. So I don't agree with the idea of us being mandatory reporters, and I think there's a lot of discussion that has to happen around mental illness. I'll also make the point that most mentally ill are victims, not committers of gun violence, right? The statistics are very, very clear that it is not the mentally ill who are going, even if you had stricter laws, Adam Lanza would have been allowed, well, his mom bought the guns, first of all, but he would have been allowed to own them, right? Even with those stricter regulations. So I don't want us to demonize the mentally ill. I don't know if you have other.
No, I would just echo that. I mean, they're at risk of violence to themselves potentially, and that's important for us to help prevent. But yeah, I would agree. Yeah, I'll just leave it there.
Other questions, or should we let you guys get to the reception?
I think there's a closing thing.
Oh, there's a closing
don't
thing
leave,
too.
Don't leave.
We're going to say let me ask one thing.
Yes, David.
If you know this, and it may be that everyone in the audience knows it, but when we talk about the restrictions on research and why the CDC is not doing it, someone had made a comment to me earlier. Why not? What is the restriction? Do you know? I mean,
Go for
we
it.
can tell.
Yeah.
Yeah, I'll try to sort of briefly summarize it. So there was an amendment that called the Dickey Amendment that basically said federal funds could not be used for to promote gun control for advocacy work. That then, because of some funding, some budgetary sort of shenanigans that occurred at exactly the same time, was taken as a de facto ban on federal funding for research related to firearms. So for from NIH, NIJ, CDC, and the effect on that was not just that it slowed down the research coming out, but it also drained the pipeline. I mean, I have also had recently colleagues say to me, are you sure you want to be doing this kind of work? Shouldn't you do something else because you're never going to get funded for it? So it's a real problem if you don't sort of keep the fund of researchers coming. So for many years, there was basically no funding until Sandy Hook, when Obama issued a directive saying, no, actually, research is fine. NIH, NIJ, you need to start funding work. And the CDC basically is still, it's all tied up in the budget. That it basically
they're afraid that
their budget gets slashed dramatically if they try to fund anything. And so it's been a very, I think it should be offensive to all of us that there's something that is clearly science and health related that are one of our biggest organizations are not allowed to address. It's clearly political, has nothing to do with science.
We could thank Doctors
Yeah,
Betz and Ranney. Thank you. We're going to have just a couple of closing remarks. And then remember, there will be a reception on the ground floor on the riverside immediately following this, okay?
Thank you all for coming. Just to clarify the comment about the Dickey Amendment, my understanding is that in the year that the amendment was passed, that there was, I'll pick a number, there was $16 million or something that CDC funded research, and the next year their budget was cut by exactly that amount. So the message was very clear. So anyway, very briefly, just thank you all for being here. Thank you for our participants. You know, when I was first given some remarks to start this, there were a couple of lawyer-doctor jokes, and I said, not for this one, because there is no light between us standing shoulder to shoulder. This is a legal issue. This is a medical issue. This is a criminal justice issue. This is a psychosocial sciences issue. And most importantly, this is really a family issue. For us as a community, for us as families, we got to fix this. We got to solve it. So thank you all for being here. Thank you, all of those of you who have shared your wonderful research, your willingness to do this from the private sector, from the public sector. We are delighted to be part of this, and thanks to the ABA for co-hosting. Thank you.
I just wanted to say a couple of things. This is a huge step, I think. The medical profession has really been stepping forward, and they have been active for a number of years, different medical societies and groups, and I think they are joining together and moving strongly. I think one of the things that we have seen from the public health research, the medical research, how persuasive this can be. I mean, when we hear this, when we see the numbers, we hear about the research, you sort of say, how could we not do something about this? How could we not? And as Dr. Miller shows, the deaths from car accidents going down, we addressed that as a public health problem. We didn't look at just who's causing the incident, but what's causing the injury. If we look at firearm injuries, firearm deaths, we can do exactly the same thing. And about this time, it'll either happen this year, it may have happened last year, those lines are going to cross. And the gun deaths, which are staying basically sort of constant, there are going to be more of those per year than from traffic accidents. The thing, so we see from this, the medical, the public health research, and just thank you to all of you in the field who've been doing such good work, and we just need to get that out more. The part that I think from the legal discussion up here, and I would mention this to the doctors and others in the audience, one of the huge things that comes from this is the Second Amendment is not a complete bar by any means to measures designed and that have been shown that can reduce gun violence. You have a particular group on one side funded almost entirely and pushed by the gun manufacturers. And that little three-letter organization, as John Lowy correctly mentioned, is not representative of its membership, which have, but it takes a more extreme view. And when you, there are a lot of things that can be done. There are measures, and we've heard about Heller and whatever comes from that is, a lot of that's been determined, but it is pretty clear that we can still have regulatory measures that don't run afoul of the Second Amendment, that can control and regulate who can have access to guns, what kind of guns they can have access to, and where they can have access to them, where they can take them. And that last one is still a little bit up in the air, but that there are reasonable things that can be done. We heard about background checks, and I don't know if everybody appreciates how simple this could be in a way, is that gun sales, when you go to a federally licensed gun dealer, they have a background check, a required background check, and if you're shown to be somebody who has committed a felony or who's done certain other things, you cannot buy a weapon at that time. Although there was a little provision inserted in that law by one side that said, okay, but if you can't figure that out in 3 days, they can still sell the gun to you. Well, that's how Dylan Roof in South Carolina got his gun. Somebody messed up along the way. They didn't get it in 3 days, and they sold him the gun. But there are a lot of things that can be done. We don't have to listen to this violates the Second Amendment, that violates the Second Amendment, everything violates the Second Amendment. The Second Amendment, although it was technically not part of the 11th Circuit decision, actually it got into the last one a little bit from the panel, but that was really a First Amendment case. But the reasoning behind it, the reason the NRA and its groups had pushed that legislation is they don't want you even talking about it. They don't want you talking about the fact that you can do something about guns in the home, that guns in the home are not necessarily safer, and that sort of thing. So there are a lot of things we can do. I think having the medical profession out front is huge, and it's huge, I guess we could say. It's very, very important. Sorry about that. It's very, very important. It can be very, very influential. We have law enforcement groups that are increasingly getting involved, from prosecutors to various levels of law enforcement getting involved. So we can do something about it. We can do something about it, and we have to get this information out to the public. Thank you very much for attending. There's a reception in the lobby. So.